Welcome to the Australian Dental Council Explainer podcast.
Glad to be here for another one.
Yeah, it's great to have you. But before we really get into the clinical material today, we do need to state a clear, professional disclaimer.
Great, the legal stuff.
Exactly. So, just so everyone knows, this content is purely educational. It is designed specifically to aid your exam preparation, and it is absolutely not a commercial endorsement of any product or publication.
Yeah, we're just here to study.
Right. So our mission for today's deep dive is, well, it's laser focused.
Oh.
We are mapping out the clinical and diagnostic framework for a highly specific, highly testable pediatric facial swelling presentation.
Oh, it's a classic OSCE scenario.
It really is. The ultimate goal here is to equip you, whether you're an overseas trained dentist, an ADC candidate, a dental student, or an oral health therapist, with the precise, evidence-based reasoning you need to navigate these complex cases.
Because the examiners, they really want to see your thought process, not just a lucky guess.
Exactly. And to do that, we are drawing heavily on the diagnostic pathways outlined in Edward Odell's Clinical Problem Solving in Dentistry.
It's a fantastic resource. Specifically, we're going to be looking really closely at the presentation detailed in Case 63, which is simply titled, A Child with a Swollen Face.
Right, which sounds so simple, but it's a minefield.
Oh, absolutely. It's a classic clinical scenario, and the way the diagnostic funnel is structured in the book, it perfectly mirrors the critical thinking that examiners expect to see from you.
So let's just, set the clinical stage. Visualize this new patient sitting in your dental chair. You have a 5-year-old boy presenting with painless bilateral facial swelling.
Just a 5-year-old kid.
Yeah. And according to his parents, he's always had a bit of a chubby face since he was a toddler. But over the past 2 years, the swelling has become significantly more pronounced.
Right, particularly around the lower jaw.
Exactly.
Yeah.
Now, medically, his background is entirely unremarkable.
It's an important clue.
Yeah.
He's fit and well. He's fully immunized according to the standard schedule.
Right, no missed vaccines.
Exactly. And his only history of childhood illness is just a routine, fully resolved case of chickenpox.
Okay, and crucially, and this is a big one, he is experiencing absolute zero physical pain.
None at all.
But the psychosocial impact here is severe. His parents are deeply distressed, and they've brought him in today because he is being actively bullied at school due to his facial appearance.
It's a really heartbreaking situation for a family.
It is. It really is. So before we go any further into the weeds here, I want to challenge you, the listener. Based on this initial presentation, what is your initial differential diagnosis?
It's a great question.
Right. So pause the audio, drop down to the comment section, and let us know your thoughts on the pinned comment. We really want to see where your head is at.
It is an essential exercise to do, because in an OSCE setting, presenting this combination of young age, bilateral symmetry, long-term progression, and a complete lack of systemic symptoms, it's deliberately designed to test you.
Test if you jump to conclusions, right?
Exactly. Can the candidate avoid jumping to hasty, panic-driven conclusions?
Okay, let's unpack this. We have our raw symptoms, but we need to run this through a diagnostic funnel, like a detective clearing innocent suspects first.
I like that analogy.
Right. We have to filter out the systemic and acute local issues before we can start, hunting for rare developmental anomalies or genetic syndromes.
Because common things occur commonly.
Exactly. So if I'm doing the extraoral and intraoral exam, my first priority is looking at the anatomical structures involved.
And Odell's text gives us those details. The clinical examination findings give us our first major structural clues. Extraorally, there is obvious, firm, bilateral enlargement of the sides of the face.
Really expanding the mandible, right?
Yes, specifically the mandible. But when you palpate the temporomandibular joints, the TMJs are completely normal in function and form.
Okay, so the joints are fine. Now, my mind immediately goes to the lymphatic system. If I see a child with a swollen face, I have to rule out an infection.
Which means you're palpating the neck.
Always.
Yeah.
I'm checking those nodes.
And if you did, you would find that there are slightly enlarged upper deep cervical lymph nodes.
Ah, okay. Enlarged nodes.
However, and this is the crucial distinction, they are non-tender and freely mobile.
Right, which completely shifts the narrative. I mean, if this were a raging acute dental abscess or a severe fascial space infection, those lymph nodes would be hot, fixed, and exquisitely painful.
Exactly. They would be highly reactive in a painful way.
Mobile non-tender nodes in a 5-year-old often just indicate a reactive state from a recent minor upper respiratory bug,
Yeah.
not a massive localized jaw infection.
Kids get colds all the time.
Exactly. So running this through our funnel, let's rule out a few other obvious culprits. Could this just be mumps? I mean, it causes bilateral swelling of the parotid glands, right?
Mumps is an excellent initial thought for bilateral pediatric swelling. It really is. But we have to look at the pathophysiology and the timeline.
Okay, break that down for me.
Well, mumps is an acute paramyxovirus infection. The swelling comes on rapidly, usually accompanied by systemic symptoms like fever, malaise, and myalgia.
And our kid has no systemic symptoms.
Right. This patient's swelling has been slowly progressing for over 2 years. Furthermore, the medical history explicitly states he is fully immunized.
Ah, the vaccines.
Exactly. Which makes an acute viral parotitis highly, highly unlikely.
That makes perfect sense. Okay, what about a muscular cause? Like an overactive jaw muscle from grinding, severe bruxism leading to masseteric hypertrophy. Kids grind their primary teeth aggressively, don't they?
Oh, they do. Bruxism is incredibly common in young children.
Mm.
But true bilateral masseteric hypertrophy severe enough to cause a visible, disfiguring facial asymmetry is a completely different mechanism.
It takes time, right?
A lot of time. To
Yeah.
build that kind of dense, bulky muscle mass requires years, if not decades, of heavy occlusal loading.
Like a bodybuilder lifting weights.
Precisely. A 5-year-old simply hasn't had the physiological time or the maximum bite force required to develop that level of muscular hypertrophy.
Okay, that's a really solid point. What about other salivary gland pathology? HIV salivary cystic disease can present as painless bilateral swelling of the parotid glands.
It definitely can. But the underlying mechanism there requires an immunocompromised state.
Which we don't have here.
Right. The cystic lymphoid hyperplasia seen in that disease process is directly tied to the retroviral infection. Our patient is completely medically fit and well, with no systemic illness or immune compromise.
So the soft tissue, muscular, and salivary gland pathologies just fall right through our diagnostic funnel.
Systematically eliminated.
Which means we need to pivot. If the soft tissue is healthy and the glands are normal, the pathology has to be coming inside the bone itself.
That's the only logical next step.
We're moving from soft tissue anatomy to skeletal genetics and dental development. And according to the source material, there are 3 highly specific questions a clinician needs to ask the parents at this exact juncture.
Yes. If you are sitting your OSCE, this is exactly where you demonstrate your clinical reasoning.
Yeah.
You need to ask the parents. Number 1, did either of you have a similar problem when you were children?
Okay, checking the parent.
Number 2, are any of this patient's brothers or sisters affected by facial swelling?
Checking the siblings.
And number 3, how exactly was his lower second deciduous molar lost?
Okay, wait. I understand the first 2 questions. Asking about the parents and siblings establishes a pedigree. It tells us we are suspecting an inherited genetic condition.
Exactly. It maps out the family tree.
But why fixate on one specific lost baby tooth? I mean, how does a single missing deciduous molar break a complex bilateral facial swelling case wide open?
What's fascinating here is the underlying pathophysiology. The condition we are suspecting is characterized by abnormal bone remodeling.
Okay, what's happening to the bone?
The normal medullary bone of the jaws is being actively replaced by a highly cellular fibrous connective tissue.
Just turning into fibrous tissue.
Yes. And as this fibrous tissue proliferates inside the mandible, it requires space. It massively expands the bone outward, causing the facial swelling, but it also creates immense internal pressure against the developing dentition.
Wow. So it's not physiological root resorption like normal baby teeth falling out?
No, not at all.
The pathology is physically evicting the teeth.
Precisely. Early, premature exfoliation of primary teeth is a hallmark clinical sign of this disease process.
It just pushes them right out.
Literally. The expanding fibroseous mass physically pushes the deciduous teeth out of their sockets well before their normal shedding time.
That is wild.
It is. And going back to the first question, asking about the parents is vital because this specific condition is inherited in an autosomal dominant pattern.
Autosomal dominant, okay.
Right. So even if the parents look completely normal now, taking a radiograph of their jaws might reveal unsuspected, healed bony defects from their own childhoods.
Oh, that is such a great detail. That connects the macro-level facial deformity directly to the micro-level dental timeline.
It brings it all together.
It proves the mass inside the jaw is actively disrupting the dental arch. But you know, clinical history only takes us so far. We need to actually see the bone architecture.
We absolutely do.
We need a radiograph.
Yes, to confirm what is happening beneath the surface and physically displacing that lost molar, the clinician must order imaging.
Mm-hmm.
And the gold standard here is a dental panoramic tomograph.
The DPT or Panorex?
Exactly.
Okay, let's break down the radiographic findings from Odell's text, because they are highly technical. When we look at the film, we see a multilocular radiolucency.
A very distinct appearance.
And inside that radiolucency, there are internal radiopaque septa. There are no dense radiopaque inclusions like you might see in an odontoma.
Right, no little tooth-like structures in there.
Yeah, and there is extensive expansion of the height and width of the mandibular body. We see gross physical displacement of the developing permanent second molars.
Pushed way out of position.
But crucially, the mandibular condyles are completely spared.
It is a textbook radiographic presentation, but I have to warn you, it is also a massive minefield for the unprepared candidate.
Here's where it gets really interesting. When you say multilocular radiolucency with radiopaque septa, almost every dental professional instantly pictures the classic soap bubble or honeycomb appearance.
Oh, absolutely, the buzzwords.
Right. And the moment dental students see a soap bubble lesion in the posterior mandible, our brains are hardwired to panic and scream, ameloblastoma.
Which is exactly the trap the examiner is waiting for you to fall into.
It's a trap.
A huge one. An ameloblastoma is a locally aggressive odontogenic tumor, and it absolutely presents as a multilocular radiolucency. But this is where you must synthesize the entire clinical picture, not just jump at one isolated radiographic buzzword.
So let's dismantle that differential diagnosis so our listeners don't fall for it. Why isn't this an ameloblastoma or, perhaps an odontogenic keratocyst, an OKC?
Let's start with the OKC. An odontogenic keratocyst tends to grow along the internal medullary aspect of the bone. It grows anteroposteriorly.
Front to back.
Exactly.
Yeah.
And it rarely causes massive, early, clinically visible buccal or lingual bone expansion until it reaches a very, very large size.
Oh.
Our patient has gross, visible facial deformity at age 5. So OKC is highly unlikely.
Makes sense. And the ameloblastoma?
Myeloblastomas are incredibly rare in children under 10.
Right. Usually an adult issue.
Yes. Furthermore, they are almost always unilateral. This patient has perfect symmetrical bilateral swelling.
Perfect symmetry. Right.
Also, look at the behavior toward the teeth. Ameloblastomas are aggressive tumors that typically cause severe root resorption of the adjacent teeth.
They eat away at the roots.
Exactly. The pathology in our patient's jaw isn't resorbing the permanent teeth, it is grossly displacing them, pushing them deep into the ramus or the inferior border.
Okay, what about a central giant cell granuloma? A CGCG also causes multilocular expansion and displaces teeth, right?
Now, that is a very strong differential because histologically, under a microscope, a CGCG and the condition we are actually looking at are virtually indistinguishable.
Oh,
Yes. Both feature multinucleated giant cells within a vascular fibrous stroma. And those radiopaque septa we see on the radiograph.
So soap bubbles.
Right. They are actually just residual wisps of original bone trying to hold the expanded jaw together.
Wow.
But again, CGCGs are typically isolated, unilateral lesions. They do not present as perfectly symmetrical, bilateral, multilocular lesions in all 4 quadrants of the jaws.
Okay, so symmetry is the key here. And then there's the final definitive radiographic clue we mentioned, the spared condyles.
Yes, the spared condyles.
The entire mandible is blown out, expanding massively, but the condyles are perfectly untouched. Why is that?
That comes down to basic embryology. The mandibular condyle develops via endochondral ossification. That's bone replacing a cartilage model.
Gotta cut cartilage first.
Right. But the rest of the body and ramus of the mandible develops via intramembranous ossification.
Yeah.
That's bone forming directly from mesenchymal tissue. No cartilage involved.
Right, I remember that from dental school.
Well, the specific genetic mutation driving this disease only affects the remodeling process of intramembranous bone.
Oh.
Exactly.
Yes.
Therefore, the condyles, being endochondral, are biochemically immune to the expansion.
That is so elegant. So, synthesizing all of that data, a 5-year-old boy, painless bilateral expansion, an autosomal dominant family history, early tooth loss, and bilateral multilocular radiolucencies that physically displace teeth but entirely spare the endochondral condyles.
It leaves only one conclusion.
The definitive, undeniable diagnosis is cherubism.
Precisely. Cherubism. It's actually named that because the massive bilateral expansion of the lower face stretches the skin, often pulling the lower eyelids down slightly.
Oh, leaving that little bit of sclera showing.
Right, giving the child an upward-looking gaze similar to a cherub in classical Renaissance art.
Recognizing this exact triad of age, bilateral symmetry, and radiographic appearance is just so key to passing this section of the OSCE.
It really is.
So what does this all mean for the clinicians standing in the room? I mean, we've nailed the diagnosis, we know it's cherubism, but anyone who has ever faced a clinical examiner knows that making the diagnosis is only half the battle.
Oh, easily only half.
The other half is patient management. Now that we know it's cherubism, how do we treat a 5-year-old who is being bullied? And how do we counsel these terrified parents who probably think their child has bilateral jaw cancer? What is the actual evidence-based treatment plan from Odell's text?
According to the clinical guidelines, the immediate surgical treatment plan for cherubism is counterintuitively observation.
Observation.
Yes, no immediate active treatment is required.
Wow, that is an incredibly difficult conversation to navigate. I mean, you have a deeply distressed family, a child suffering real social consequences, and your medical advice is essentially wait and see.
Yes.
How does a candidate deliver that management plan in an OSCE, or real life for that matter, without sounding totally dismissive of the patient's very real suffering?
If we connect this to the bigger picture, this is where we recognize that empathy, backed by a deep understanding of pathophysiology, is a highly technical clinical skill.
I like that. Empathy as a technical skill.
It is. You cannot just say, oh, it's a benign genetic condition, wait it out, and send them on their way. You must provide profound reassurance by thoroughly explaining the biological timeline of the disease to comfort the family.
So walk me through that timeline. What exactly is happening to the cellular biology as this child ages?
You explain to the parents that the fibro-osseous lesions in cherubism are highly active and they grow the fastest before the age of 5.
Okay, so right now.
Exactly. This means the most aggressive phase of the facial expansion is already peaking. As the child enters their early school years, the growth rate of the lesions will dramatically slow down and stabilize.
But it doesn't just stop there, right? It actually reverses.
Exactly. The condition is entirely self-limiting. As the child approaches puberty, a massive physiological shift occurs.
Hormones.
Right. The influx of hormones, combined with skeletal maturation and the cessation of primary jaw growth, it fundamentally alters the bone turnover rate.
So the osteoclastic activity decreases.
It decreases, and the fibrous tissue within the jaw begins to spontaneously regress. It is slowly naturally replaced by normal lamellar bone.
So the body essentially heals itself from the inside out.
Yes, complete clinical resolution of the facial deformity usually occurs by age 25. By adulthood, the facial profile will return to a normal contour.
That is amazing.
And because this is a self-resolving childhood condition, aggressive surgical intervention is heavily contraindicated during the active growth phase.
Because surgery would carry immense collateral damage, right?
Absolutely. Attempting to surgically resect or heavily contour these massive, highly vascular lesions in a 5-year-old would risk catastrophic damage.
To the permanent teeth.
To the developing permanent dentition buried in the jaw. Absolutely.
Yeah.
Not to mention the extremely high risk of severing the inferior alveolar or facial nerves.
So are there any exceptions where surgery is justified?
The clinical literature notes that surgical intervention is generally not necessary unless for severe cosmetic reasons. And even then, usually only after the active growth phase has burned out.
Right, once things have stabilized.
If the resolution is abnormally slow, and the psychological impact, like the severe bullying, remains completely debilitating, minor surgical contouring might be discussed with an oral and maxillofacial surgeon. But routine curettage or resection is very poor practice.
Got it. And we can't forget the genetics. We established this is an autosomal dominant trait.
Which brings us to the final critical step in the management protocol. You must counsel the parents on the genetic implications.
Right, for future siblings.
Exactly. An autosomal dominant trait means there's a 50% chance that any future children they have will also inherit the mutated gene. Therefore, referring the family for formal genetic counseling is an appropriate and mandatory part of the comprehensive treatment plan.
You know, that completely reframes the clinical encounter. You aren't just looking at anatomy and reading a panorex, you are managing a family's psychological state by providing a predictable biological roadmap.
It gives them hope.
It does. Rapid growth, early childhood, stabilization, and then spontaneous regression triggered by puberty. It turns a terrifying unknown facial deformity into a manageable temporary developmental process.
And in an exam setting, A candidate who can confidently explain why observation is the superior medical choice, rather than just memorizing a rigid do-nothing guideline, will score exceptionally well.
Okay, let's do a quick final review of the journey we took with case 63. We started with a painless bilateral pediatric mandibular expansion.
Right.
We utilize a diagnostic funnel to rule out acute viral infections like mumps based on the timeline and vaccine history. And we ruled out masseteric hypertrophy based on the patient's age and physiological limits.
The obvious stuff first.
Yep. Then we identified the critical clues of early premature tooth exfoliation and an autosomal inheritance pattern.
The genetic clues.
We analyzed the panorex, differentiating the bilateral condyle-sparing multilocular radiolucencies of cherubism from aggressive tumors like ameloblastomas that typically resorb roots instead of displacing them.
Avoiding the soap bubble trap.
Exactly. And finally, we formulated a conservative, reassurance-based management plan, prioritizing long-term biological regression and genetic counseling over hazardous, unnecessary surgical intervention.
It perfectly illustrates how systemic pathology, dental development, and radiographic interpretation are inextricably linked.
It really does. But before we wrap up, this raises an important question, a final provocative thought for our listeners to ponder.
We'll have a good one for this.
Let's hear it.
So the text notes that while the physical facial swelling resolves by age 25, the internal bone architecture doesn't always remodel perfectly.
Right.
The radiographic changes, those massive multilocular radiolucencies, can often remain visible as dormant scars inside the bone well into a patient's 30s or 40s.
Wow. Into their fourth decade.
Exactly. So imagine you have a 35-year-old new patient sitting in your chair. Their face is completely symmetrical. They look totally normal.
Okay.
But when you take a routine screening panorex, you see massive, healed, multilocular radiolucent lesions spanning their mandible.
That would be terrifying to see on a film.
How will you ensure you don't panic, misdiagnose these historical dormant bony scars of childhood cherubism as a brand new, active, highly aggressive pathology and subject that patient to an entirely unnecessary and invasive bone biopsy?
That is a fantastic clinical question to leave them with. For more dental examination prep tips and clinical deep dives, please subscribe our Spotify and YouTube channel and share this episode.